All right, so thank you all so much for being here today. I am very excited about today's presentation. So with us, we have Zoe Brokos from Church of Safe Injection, and she will be talking with us about harm reduction. So Zoe, I'll go ahead and turn it over to you.
Great, thank you. Hi, everyone. I'm Zoe Brokos, and I am the director of the Church of Safe Injection. We are a Maine CDC certified syringe service program, and we operate primarily in Lewiston, Westbrook, and Rumford. And work really closely with the other harm reduction organizations that do similar work to us in other parts of the state. So all in all, across the state, we have pretty decent coverage. I'm going to talk today, I'm going to offer a broad overview of the concept of harm reduction, which I think we're starting to hear more and more. Back when I started doing this work in 2010, people really didn't know what we were talking about when we talked about, providing safety and support for people who were actively using. And what we are seeing now today is harm reduction being used in a variety of ways, which is a very beautiful thing, but also, requires a really solid understanding of the foundation, so that we can ensure people are using the kind of philosophy behind it and the initiatives appropriately. So this is a little bit about us. We'll get into more of the broader descriptions of harm reduction in just a minute, but I always like to start with just what our mission is and why we do the work that we do. I included it in the summary of the training that I sent around, but our organization started in 2018 by a young man named Jesse Harvey. Jesse had a big idea, which really his goal was to create a space, a church, an actual religious organization where people could use drugs safely inside of that space and be protected because it was part of their religion. Jesse died in 2020 of an accidental overdose. He died alone in his home. And so those of us who took over the organization after he died really had to scale back on that really big vision of his, because Jesse was brilliant, and not that we aren't all still brilliant. His idea was so big and so vast. And we were really worried about the practical stuff, like how are we going to pay our staff and pay rent? And so we've really kind of scaled back his mission to this mission, which is really to provide harm reduction services in Maine, while really recognizing and lifting up these things that really increase risk and increase harm, that could very much be fixed, right, by aspects of our society and by our communities. We're an organization that is run by queer people who use drugs, and that is something that we're really proud of saying out loud in all the spaces, because it's not often that people can really talk about what their drug use looks like and celebrate it in a way that feels safe. So we do it when we can. Couple of quick data points, and the reason why this data is from 2022 is we actually just overhauled our data collection system, and we're going to be using a brand new system, which is a lot easier to kind of run reports and pull data from. But we opened our Lewiston program in February of 2021, and so by 2022 we had over 1,000 participants, and collected, almost 70,000 syringes, and gave out just as many as well. And so just a quick quick overview of syringe service programs. Syringe service programs have been around since the 80s, really starting as a response to the AIDS epidemic. And that response came from the realization that blood found in syringes that were used for injection were possibly transmitting HIV. And so needle exchange programs, as they used to be called, started illegally, just passing out clean syringes to people who needed them, really because, people are going to use drugs. People use drugs for a variety of reasons. And the belief of harm reduction is really that everyone deserves to be healthy and safe. And so needle exchange programs, syringe service programs are an infectious disease prevention tool. Here in Maine, we have very low rates of new HIV infections each year, typically between like 30 and 50, but we have incredibly high rates of hepatitis A, B, and C. And so syringe service programs are incredibly effective in reducing new transmission of hepatitis by providing clean syringes and clean equipment that people use for injection, as well as clean equipment for people who smoke their drugs instead of inject them. And then we also provide a safe place to dispose of used syringes and have access to testing for HIV and hepatitis and educational materials. And then, as you can see, we distribute a ton of naloxone. Naloxone is the generic name for Narcan. Narcan works to reverse opioid overdoses. We receive tons of overdose reversal reports and really have a unique opportunity to get those reports directly from the people who are at highest risk. And so people who are actively using, who are actively reversing overdoses, coming in, getting naloxone from us, telling us about the last overdose they reversed and what that experience was like, and then getting more. I can say I learned that fentanyl was in Maine, not by a toxicology test, but by starting to hear a change in the overdose reports that I was getting from my participants back in 2015. Things started to sound different. And we saw this in Maine and New Hampshire, and we knew that something had changed in the product. So those overdose reversal reports are incredibly useful for those of us who provide education to people at highest risk to experience an opioid overdose. And so according to the National Harm Reduction Coalition, which if you aren't familiar with their organization, they're an incredible resource for harm reduction materials. There's webinars and online trainings and materials that you can print out, really incredible work they have been doing for a long, long time. And so this definition is one that they use quite often. And it really is this idea that there are practical strategies that can reduce some negative consequences that are sometimes associated with some drug use. I put a lot of sums in there because not all drug use is harmful. Not all drug use causes negative consequences, but some does, certainly. And so having that education and being able to make that choice about your own use and what that looks like in that moment is incredibly empowering. But harm reduction is also this larger movement for social justice, which really started with queer people, Black and brown people who were dying of AIDS and really took this on themselves to keep each other safe and to keep each other alive. And so harm reduction can look like a lot of different things. It's not just drug use, although for us and our organization, it oftentimes is drug use and related other things, right? We talk a lot about harm reduction with smoking. A lot of people who want to quit smoking cigarettes, a lot of people who want to stop injecting drugs or want to reduce the amount that they are overdosing or, reduce the amount that they are experiencing necrotic wounds and blood infections from their injecting techniques. So we really keep harm reduction pretty focused on drug use at COSI, but these are some great examples of when you can use harm reduction in other ways. I'll say I also use harm reduction techniques every single day with my children, with my 10-year-old and with my 20-year-old. Very different techniques, of course, but very often it can really just look like providing some information if the person is interested, right? Like asking permission, offering some suggestions with no expectations attached to those, seeing how they land, and then like leaving it there, which can be really, really challenging, especially when we are working with somebody who seems like they're in a lot of danger, seems like they're really harming themselves, seems like they're really struggling. It can be really hard to show up without judgment and create a safe space to talk about whatever it is, whether it's substance use, whether it's overeating, whether it's somebody who is smoking or not wearing a seatbelt. It could be really anything. Like here are the facts, here is the information. Now you know, and now you get to decide what you want to do with that. I've been doing that with my children for a long time. And when we talk about how empowering it is for somebody to be able to make their own decision, and how incredibly devastating it can be to give somebody unsolicited advice, especially folks who are told what to do all the time, right? Like people who are unhoused, people who are incarcerated, children, right? These groups of people that we just assume they want to know our knowledge because we are so smart. So harm reduction is really just an incredibly beautiful opportunity to sit with somebody with nothing but love. And that was really one of the main concepts that certainly I, among hundreds of other people, learned from Dan Bigg. Dan Bigg worked for the Chicago Recovery Alliance and distributed naloxone to organizations all over the country before naloxone was legal for lay people to have. So I can say without a doubt, the first naloxone that was distributed here in Maine was definitely from a package that came from Dan. And so these were Dan's kind of harm reduction beliefs, and I think they're really beautiful. And I encourage anyone who wants to borrow them or use them or change them slightly to feel free to do so, because it really does come down to, I think of number 6 as really being the way that we show up for people every day, that like any positive change should be celebrated. And even that feels a little judgmental to me. Like I would like to just say anything can be celebrated. I mean, sometimes we see people who come in, who have been injecting drugs and sleeping outside. They're unhoused. Their skin is really dirty. They don't have access to running water or electricity, and they're getting horrible abscesses in their arms. And we've been talking about safer injecting techniques and encouraging them to use alcohol pads prior to injection, and still, that hasn't happened. The day that person comes in and just asks for an alcohol pad when they come to get their supplies is a huge positive change in my opinion. And even if they don't use it might take another month before they use that alcohol pad, or maybe they never do, but they end up washing their injection site with soap and water. So there's a lot of different ways to embrace and celebrate someone making a decision for themselves, even if it's one we don't agree with. And always, 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 and this is hard for those of us who talk a lot for our jobs, but number 10, like less talk, more action, and more listening. I see that a lot in our office, where folks come in and are greeted by staff, and then staff just talk at them for like 5 minutes and don't once stop to listen to what the person has to say. And I think we do that more than we maybe realize. But really embracing harm reduction as this opportunity to recognize and accept that drug use is a part of our culture. It's a part of it has been a part of our history and our world for a long time. We are not going to get rid of drugs anytime soon. What we have seen is what we will continue to see, which is that the drugs will change, they'll shift, they'll probably become more dangerous the more we restrict them and the more we incarcerate people for having them, for using them, for moving them around. Fentanyl has really changed the way we do everything as harm reductionists, just because of how strong it is and how inconsistent it is. And so we'll talk about that a little bit more in a minute. But really kind of embracing what we learned from our founders. This picture here on what is that? The right, yes, with the flowers and the rocks. That young man who's holding what is actually, yes, a golden oyster mushroom. That was our founder, Jesse Harvey. And then the picture next to him is Carrie Morissette, who was our director who took over after Jesse died. And we lost Carrie in May of 2022, also from an accidental overdose. And so after we lost Carrie, I stepped in as director. Mark Kinsley here on the other side, he really is one of our teachers who taught all of the East Coast about harm reduction and how to sit with people and how to walk alongside people in a really beautiful way. So just always feels important to honor them. You can learn more about Mark, about Dan, about Jesse and Carrie just by Googling their names or going onto the Harm Reduction Coalition website. So I want to talk a little bit about the peer navigator work that we do through our harm reduction programming, because we provide it in, as you can see, these 3 counties. And it really is an extension of the harm reduction work we do at our brick and mortar location in Lewiston. So our brick and mortar, like our office, is in Lewiston. That's where people can come in and come into our syringe service program, access supplies and other resources and services like testing for HIV. We did a vaccine clinic for hepatitis A a couple weeks ago. We have Maine Family Planning who comes in and does, access to birth control and, access to hormone therapy and abortion services and STI testing. So that's Lewiston. And then our other sites are all outreach based. And so it's our peer navigators who operate in our outreach sites. So Westbrook, Rumford, and then we have outreach workers in Lewiston. And then we have 2 outreach workers in the Portland area as well. And so they're in the community working with people who use drugs, helping to connect folks to resources and supplies as needed. We are open Monday through Friday, right? Like 10 to 4. And so it's really challenging for people who work or for people who can't get to our locations to have access to clean supplies. And we know that when people have clean supplies, they're more likely to use them. And we also know that if people don't have clean supplies, they're more likely to share a syringe or share some of their other equipment with an individual. And there's real harm that can be caused by sharing syringes and sharing equipment. And so making sure people have adequate access to the supplies that they need and disposal of sharps and access to naloxone with education on like sort of best practice for reversing an overdose is really important, that we're like out in the community working with folks and helping them get connected to our resources, but also spreading the word about the other work that we're doing. So we currently have a team of 12, and we have 7 part-time peer navigators who are either duly certified as recovery coaches and peer support professionals or in the process of doing that. They're also all being trained in motivational interviewing and are CPR first aid certified and, really, really intended to be there to support individuals who are at highest risk or who might not be coming in and accessing our services. So please know that's always a resource. You can learn more about our peer navigator program from our website, which I have up at the end to share with everyone. The Peer Navigator program is a program that's funded through the state. It's a pilot program funded through the Maine Office of Behavioral Health. And so we're just finishing up year one. And we've been really pleased with what we've seen and what we've accomplished so far. And then we're starting year two in October. So if you ever are working with clients, and it's somebody who might benefit from connecting with one of our peer navigators, depending on where they're located. It is like location based, but we can be pretty flexible. If it's Cumberland County, we can make it happen. Same really all three of our counties, like we have pretty broad access and people who provide transportation. So if you ever have somebody who wants naloxone and isn't sure how to access it, needs clean supplies and doesn't know where to go, has questions because they have a loved one who's using, and they just want to know more about what that means, and they have a bunch of questions, send them. You're always more than welcome to send them my way or just in general to our organization. Trainings like this and technical assistance and support, which can be more kind of focused around like how to develop an overdose response protocol for your program, or how to incorporate harm reduction trainings for all new staff or new volunteers, depending on what the group is looking for. We provide a lot of training and education like we're doing today, and then also kind of like more focused in specific areas. So there's a huge value of this idea of really offering peer-led programming. It's really about the power dynamic, and there isn't much more that can be said, because even when we are so intentional and so careful about the way we ask questions or how we treat somebody who is feeling ashamed or has felt ashamed about something that they're doing, us just being in this position where there is a power difference, makes it really hard for somebody to hear that the way we intend it. And I've felt it, I've witnessed it, I've done it. It's really true. It's incredibly hard. I mean, I even notice it with my team, of course, right? Like I'm the boss, even though we try not to do all of that. Everyone has a voice, everyone has a say, we take votes, we do all the things, but like I still get called the boss at the end of the day. And so I think having peer-led programming can really help reduce some of that. We're about to open up a community center up in Lewiston that will be a peer-led community drop-in center for people who use drugs and for people in the community who don't have anywhere safe to be, and really trying to develop this program that essentially runs itself, that everyone is a peer, everyone's helping out. If the trash needs to be taken out, someone takes it out. It doesn't need to be, doesn't need to wait until someone tells them to. So these bullets, I'll kind of let you all read through as I'm talking, but I think they're really important to think about whenever we are in a position to offer anything, and how we want to ask for permission to do that, and then how we want to do it. My favorite thing is when we ask permission and the person says no, like how difficult it can be to not still do it. And I see it happen all the time, but like, if we say, can I offer you a suggestion? And someone says, no, don't offer the suggestion, wait, you're building that foundation of trust. And I think, with harm reduction, there's a lot of that. There's a lot of like the slow moving end goal of building trust. When you meet somebody for the first time, if you jump right into asking them about their drug use and their childhood and why they use drugs and have they ever gone to treatment and, are they thinking about getting sober? There's no way that person, it's incredibly rare that you're going to meet somebody who is comfortable and interested in telling the truth of that experience and leave not feeling harmed. And so with harm reduction, we really strive to build on that foundation of trust first. And that can take a week, that can take 3 weeks, that can take 6 months. I always tell my outreach teams when they first start in a new location to get comfortable, because they're going to be sitting there by themselves for a long time before people start to feel comfortable coming to kind of ask what they're doing and check out our services. And so it's our job to show up consistently and be there when we say we're going to be there. And eventually people are going to start showing up as well. But I know, because I did it, that sometimes you have to sit on the corner of Oxford Street in Portland for 12 months, and just show people that you are showing up for them. And then they will start to come, because it's all about trust. It's really about, helping people to not feel like there is any expectation or there is any shame or judgment associated with the decisions that they're making, or just where they're at with their relationship to substances right now. Because substance use changes, and I've been using this continuum for a long time. I think it's really interesting. I've changed the way I feel about it over the years. I kind of describe it differently now than I used to. But we really try to be incredibly mindful of the language that we're using when we're talking in community about drug use, because the language itself is so harmful. I think we all know now, we try not to say addict, or we try not to say substance abuse. There's new terminology per SAMHSA that people are saying, and trying to say substance use and substance use disorder. And I think that we can do better than that. I don't believe that all substance use is a disorder. And I think there's more to explore there. And it's not just me, like I'm coming up with this. This is really, one of the core beliefs of harm reduction, is that there are drug use changes depending on the situation, depending on who you're around, depending on what you're using. And so not all drug use is bad. Not all drug use is harmful. We really try to use the language chaotic substance use or chaotic drug use to indicate somebody who, is using drugs in a way that probably is related to the harms that they're experiencing. Other people have a different relationship with substances, which is also how we like to phrase it. So instead of asking like, what does your drug use look like? Or how much do you use? What does your relationship with substances look like? And people might use language when talking about themselves, and we're certainly never going to correct somebody in a situation like that. But we, as providers, as educators, as people who are supporting individuals who are oftentimes using drugs, I think being mindful of the language that we use is really important. So either calling somebody a person who uses drugs, which is my preference, or a drug user, or what does your drug use look like? What's your relationship to substances like? Because what we see oftentimes is that, someone might be using really chaotically, and then something shifts, right? They either go to jail, or they get housed, or they start taking medication for their, untreated mental health diagnosis. And that drug use oftentimes changes and is no longer compulsive and chaotic. It shifts a little bit. And so I think making a lot of space for what drug use looks like is important. We hear people say, oh, I use fentanyl, I use opioids, I use dope. And it's immediately assumed that must mean, number one, that they're injecting, and number two, that their drug use is probably completely out of hand. And that's also not true. Just like it's not true that people can't use cocaine every day and function in the world, right? Like drug use is as safe as it can be, depending on the resources that an individual has. So the best thing that we can do to support people who are using drugs is help them identify the resources that they want and or need to be as healthy and safe as they want to be in this moment. And then we can continue to talk about it. We can continue to shift what that looks like and how it changes when somebody gets housed, when somebody loses their housing, when somebody has young children in the house, when somebody's on probation. Possibilities are endless. I was going to stop for questions, but I think I'm going to try to just get through the next couple slides so that we can then open it up for questions at the end, unless anyone has like a burning question that they want to ask right now. Okay, great. So a couple of numbers just that I think are interesting as we start to talk about overdose education. I think anyone who is in a position to talk to individuals about things that help keep them safe, and that's really about as broad as I can make it, but therapists, psychiatrists, psychologists, counselors, everyone is in a position to offer something really beautiful, which is access to naloxone. And so we're going to talk about what that looks like. But first, it's really important to know why we're seeing what we're seeing. So in 2023, there were over 3,000 fatal and non-fatal, right? So overdose reversals are included in this number. That's how many overdoses occurred. Well, that's how many overdoses were reported to EMS within the first 4 months of 2023, so January through April. And within that same time frame, there were 200 fatal overdoses. So out of those 3,000, there was 200 fatalities. And yet, in our harm reduction organization and the other harm reduction organizations in the state, we get tons of overdose reversal reports, which is essentially a non-fatal overdose. The issue is that it's really hard to capture that information in real time. Sometimes people will come back and give us an overdose report from 6 months ago. So we know that this community overdose reversal report number is incredibly inaccurate. And it's just like really hard to come up with a way to have overdoses reported almost immediately, because a lot of the times people do not call 911 to report an overdose. If you have naloxone and you know how to reverse an overdose, and potentially you're somebody who uses drugs, which means you might have something illegal on your possession or in your home, there's a really good chance that that individual is not going to call the police. And so making sure that people have naloxone or Narcan and know how to use it. It can't just be handing somebody Narcan. It has to be that educational component of making sure they understand what it's for, what it will work, what it will look like while it's working, and what you can do to help keep the person safe while the naloxone is absorbing into their system. So we know that illicitly produced fentanyl, which is essentially non-pharmaceutical fentanyl, continues to be responsible for the majority of the overdose fatalities in 2023. And I can say that both of our founder and our previous director, who both have died, both had fentanyl in their system at the time of death. Like, there is no heroin in our state. I mean, there's a little bit, but the majority of the product that's sold on the street that people call dope or call heroin is almost entirely fentanyl. And that doesn't mean that it's always really strong. It's usually cut with some other product of some kind, but it's different. And so it's different, it's inconsistent, and it's incredibly, people become incredibly dependent on it because it's a very strong opioid. So still responsible for the majority of the fatalities. And we've seen a wild increase in methamphetamine use. And we've seen xylazine, which is a tranquilizer, pop up certainly all over the news, but also in the opioid supply as well. So it's quite common for someone to test positive for fentanyl and xylazine. And that's really important information for us to be able to talk to people about, because when you're educating on overdose prevention and overdose risk reduction, it's really important to start with what puts somebody at risk. And so there are a couple of things that are really critical that if you are talking to a client or to a patient and you hear them say any of these things, it is an opportunity, it is a gift, it is a chance to offer them naloxone. And I'll say, when it comes to building foundations of trust, something like that goes a really long way for somebody who is unsure of trusting people. So this inconsistent and unknown supply, aka the presence of fentanyl and other non-pharmaceutical laboratory-made opioids, plus mix in these tranquilizers and these other substances. The inconsistent supply has a huge impact on the number of fatalities. When people first get out of jail or prison or the hospital and their tolerance has changed, they haven't been using as much, they're going to experience an overdose potentially. Mixing substances, if you are knowingly or unknowingly mixing benzos and alcohol, or benzos and opioids, or opioids and stimulants, it's really recommended that people try to stagger what they're using. Now, I will say that it's also not very common that people will take that advice. But it might mean that they try something else a little bit different. Like maybe they don't take them both at the exact same time, but they're willing to do one right after the other. Like, celebrate that. That's huge. And then people who are new to using, of course, if they're inexperienced, if they've never used opioids before, and then using alone. And that one is so common. And it's also incredibly difficult to get somebody to stop doing it. And number one, because we can't get anybody to stop doing anything that they don't want to do. But because for a lot of people, the practice of using drugs, of preparing drugs, of getting your drugs ready, and if you're injecting, there's a whole bunch of steps along the way, and people have their kits and their special items that, it really is incredibly ritualistic. So trying to incorporate other safety steps can be really challenging. And so we know that people who use drugs alone are doing it for a reason. They're not just like accidentally forgetting, to tell somebody that they're going to get high. Of course, that might happen, but a lot of the times it's because the person lives alone, or they are hiding their use, or they don't have anywhere to live and they're using in a public bathroom, or outside, or in a dumpster, or, all of these different examples of just what being alone looks like. And it can be really hard to talk to somebody about. Yeah. So I want to just stop there for a second, because I think that talking about overdose is super heavy and intense. But I also want to make sure that people have a really good understanding of how you can kind of quickly walk through the steps with somebody about how to reverse an overdose. There's tons of great videos online. Again, National Harm Reduction Coalition has great resources. We do group trainings, just making sure that people feel really comfortable with what the steps are, because you want to make sure people know how to do rescue breathing, ideally. And then these are some other ways that we can reduce the risk of overdose that we believe are really important, either next steps that we don't have happening yet, or things that we should really be promoting funding for, right? So we give out naloxone. It's through the state. It's money that the Mills administration has in the budget. So it's free to us, which is great, but it also still is very expensive for somebody who doesn't access a syringe service program. Not everyone knows where you can get it. It is now available over the counter. I can say I don't really love that because, again, I think the opportunity to educate somebody one-on-one or as a group about overdose and how to respond is so important. I've never seen anyone outside of a harm reduction community member or a person who uses drugs or is like medically trained in some other way. I have never seen somebody like truly respond appropriately. Because it's scary and you don't know exactly what to do. But if you're interested in learning more about some of these risk reduction recommendations, there's tons of information all over the place. You can just Google fentanyl test strips, comprehensive drug checking programs. We are about to roll out ours. State of Maine passed a law last year that allows programs like ours to test people's drugs and get a full panel of what is in that substance so that then the individual can have that information and make a decision about what they want to do. So, you know, when fentanyl first came around, we didn't know what it was. And so people weren't familiar with it. And so they had to change the way that they were using. Now that we know that everything is fentanyl, then okay, it's not such a big deal. But when there's tranquilizer in there, when there's other substances in there, it changes again. So being able to test substances right when people come in and give them the results is going to be huge. So that's rolling out soon. And our community drop-in center is opening soon as well. So I'm just going to breeze through these quickly because I want to make sure we have time for questions. But I think you'll all get the recording of this. Feel free to take your time in looking through these steps, and really here in this blue box, you know, the steps to reversing an opioid overdose are really simple. Determine that the person is unresponsive. Give them naloxone, call 911, and wait with them until the emergency, you know, the EMTs have arrived. Now, oftentimes police are also sent when you call to report an overdose, but not always. And ultimately, it doesn't matter if they do or not. There are things that you can do almost immediately while you're waiting for anyone else to come, and giving naloxone as quickly as you can once you've determined that somebody is either not breathing at all or they're breathing so shallow that they're like turning blue or turning kind of gray. So that color change is an indicator, but unresponsiveness or not being able to detect breathing is the number one thing you're looking for. Naloxone cannot hurt somebody if it's given to them by mistake. It just doesn't do anything. It works by bonding to the receptors in the brain where opioids should be or are, and blocking the effects. And so if there's no opioids in the person's system, the naloxone is just not going to do anything. So you don't have to worry about that. Naloxone is available over the counter, like I said, in certain pharmacies. It can also be written as a prescription from a doctor if the person has insurance, or you can send somebody to one of the harm reduction programs throughout the state. And we all are always, you know, providing naloxone to folks. So we talked about xylazine a little bit. It's a tranquilizer. It intensifies the effects of the opioids, which is why it is so problematic when a person overdoses, because it's really hard to tell when they're, you know, when they have come out of the emergency, like their breathing is normal. It's sometimes really hard when xylazine is present. And just as an aside, I think we're hearing a lot about xylazine. It will be something else soon. So I've seen a lot of people like scrambling to make pamphlets and posters and info videos about xylazine. And yes, of course, it's dangerous and we want people to know about it. But we want people to have access to education and empower them to have access to a full panel of what is in someone's drugs so that they can make a choice. Okay, I'm gonna stop here because we talked about drug checking a little bit, and I'll make sure you have a chance to look at the other slides that we have, which really I just kind of got into our wound care programming that we do, which is really critical for people who are unhoused, just to be able to come in every day and have their wounds looked at and their dressings changed. Like, it's really great. So let's open it up for questions.
Yeah, if you want to unshare, that way everybody's picture will be a little bigger.
Ah, there's everyone. Great.
All right.
Sorry. I like rushed through the end. So please, if there's anything that anyone wants clarification on or wants to talk more about or has a general question.
While folks are formulating, I just want to say thank you so much. This was so excellent. And
Great.
yeah, I think something that really sticks out for me is just, when you talk about the sort of principles and philosophies, my response is like, oh, yeah, that's so related to, I think, how many of us approach therapy. And yet, I think there is this experience of like, you stick the word drugs on the end, and everybody has this very different experience, even though the philosophies are incredibly similar. There's so much overlap.
Yeah. 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 I think that's a good point.
I don't think I have a question exactly, but I'll just share kind of related to Lauren's point. So it was so grateful. I'm very grateful for your presentation, because I think I also feel sometimes as a therapist that this sort of like, okay, like, yeah, I might be able to apply this harm reduction approach to other areas of my work, but as soon as it's a substance, I feel this pressure to be like, okay, has to be abstinence, and this is how I have to be thinking about it. And I'm a DBT therapist, so it's sort of this like, oh, if someone becomes a target behavior, and how am I supposed to sort of, go to zero? And but at the same time, I'm supposed to think dialectically about it. So anyway, I think there's just this. I appreciate the framework, and that it might, again, it's going to depend on the client and what their goals are in therapy, but also that it doesn't, I don't have to sort of like, sometimes I feel stuck also when I'm going towards abstinence, because it's not their goal, or it's not even maybe just possible for them where they are in their lives at that time. So I appreciate this alternative model.
Yeah. Yeah. I was just going to say, I had a really beautiful conversation with a couple of mothers last year who were telling me about their sons who were both in active use. And, they were so quick to tell me that, they kicked them out of the house and they won't give them any money, and they know that they need to hit rock bottom before they can get better. And I offered some harm reduction suggestions, and they both just like started crying and were like, we didn't know that was one of the options. And it's true, we don't talk about drug use like that. It's like, you just have to stop. You don't do drugs, whatever you do. I mean, I hear people say it to their kids all the time, right? Don't do drugs, don't do what I did, just never smoke cigarettes, all these things. It's like, well, they're going to do it if they are, wouldn't you rather make sure they have the education so that they can make an informed decision? And that decision still might not be the one that you're hoping for, but yeah, I think it can be another option. No other questions?
I suspect people are formulating, but I'm wondering, also, I mean, you touched on this a little, but I'm just thinking about how you sort of manage maybe any urgency you feel when you sort of see that someone might be over on that chaotic side, and maybe they're not viewing it in that way. And so managing your urgency so it doesn't turn into like, I might sort of want to guide you, even though my job is actually just like to meet you where you're at, when that urgency is, yeah, based in like anxiety or fear, and just knowing that like preserving autonomy is kind of at the top for this approach.
Yeah, I think that is the challenge right there. We all have those couple of little things that's like our triggering spot. And I can say for me, it's always pregnant people and people coming in with children. As a mom, it's really hard. And it took me a long time to be able to recognize that and then work through it. And I think the most helpful thing is to have a team. There always should be an opportunity to deconstruct your day or your interaction that you just had, have someone offer some suggestions, some feedback. The work is really challenging, and it's not possible to always be working with somebody else. But I really have always taken kind of the same concept of, having an intern or working with a professor, or working with someone, who's a mentor, or working as an apprentice, of really having a supervisor, having somebody who is able to supervise what's going on and offer something afterwards, because you don't always recognize it. And I see this with recovery coaches in our community a lot. Governor Mills had a beautiful idea to have like 250 individuals from the recovery community trained as recovery coaches. And so they set up this whole recovery coach academy, gave everyone a 1-week training with like a 5-minute block on motivational interviewing, and then sent them out. And everyone was like, well, wait a minute, what now? Like, who do they talk to? What happened? Like, do they have the resources? There can just be so much. And I think that really getting good at checking ourselves when we recognize, like, okay, this person is, I think they're using really chaotically, and I'm going to swoop in and help them because we, want to save everyone all the time. And just being like really trying to just stay really present with that and recognize when it's coming up. I've even said it to people, people that I have built relationships with. I've said, oh, it's really hard for me right now to see you like this because, the last time we talked, whatever. And like today, I'm having a really hard time, right? Just like really keeping it centered on me and what I'm struggling with. And also, there is nothing wrong, and this is something a mentor taught me a long time ago, the good old-fashioned apology when we don't get it right really goes a long way also. It really does. Just like, hey, I feel really, really uncomfortable about the way we left things last time. I was feeling really, like modeling that. And we try to do that at COSI a lot. I have a lot of staff who are very young and pretty inexperienced. And so modeling the way we do that can be really beautiful. Good question about the shelf life of naloxone. So when you purchase it, you will see that it typically has, I don't know what they're going to have on the over the counter, honestly, but it's typically a 2-year expiration. There is so much research in the world that will tell you that naloxone is going to work well past its expiration date. But of course, in certain situations, we can't exactly give out expired medication. But if I were to give somebody naloxone and they brought it home and 5 years later, somebody's overdosing, it's going to work. Typically, when I write overdose response protocols for an organization, I have it kind of switched out annually. And there's actually places where you can donate your expired naloxone so you don't have to throw it away.